Wonderful. Hi, everyone. Thank you for joining us today for MVC's first Health in Action Work Group of 2024. My name is Christy Degner, and I'm the Site Engagement Coordinator for MVC. I look forward to facilitating this work group for you all today. Today's Health in Action Work Group will feature a presentation by Belinda Dokic of Trinity Health, who will be discussing the use of risk stratification tools to improve clinical outcomes. Belinda currently serves as a clinically integrated network manager for Trinity Health. Belinda is a high-performing certified Lean Six Sigma Black Belt with more than 10 years of experience in quality, project management, and process improvement, and more than 20 years of working in a variety of healthcare settings. Thank you, Belinda, for being here today. And before you begin your presentation, I have a few brief housekeeping items to review. The first is the session is being recorded. The slides and the recording will be shared with all attendees following the work group. Next, we will be monitoring the chat throughout the presentation, so feel free to add questions there. We'll also have some designated time at the end of Belinda's presentation for a Q&A and discussion. And lastly, your feedback is very important to us. If you could please complete the post-work group survey in a link that will be provided at the end of the work group in the chat, as well as in the email follow-up, that would be greatly appreciated. And as a reminder, for hospitals participating in MVC's component of the P4P program, in order to get engagement points and attendance credit for this work group, you do need to fill out that survey. So it's mandatory for the hospitals that are hoping to get credit for the work group. As a reminder, if everyone could just mute themselves when joining, if you're not actively talking, that would be greatly appreciated. Wonderful. Belinda, I will pass it over to you for your presentation. Thank you again for joining us today.
Thank you. I'm going to go ahead and share my screen. Hopefully you can see it. Can you see my screen?
Yep, it looks great.
Okay, great. So good afternoon, everyone. My name is Belinda Dokic. I'm from Trinity Health. Actually, my current role is a clinically integrated network manager for Southeast Michigan. It's a statewide department. We have CIN in Southeast Michigan and West Michigan, and now as of 6 months ago, we merged two, and now we are statewide CIN. So I'm here to talk to you about EROR, or Epic Risk of Readmission model, which is a logistic regression model that predicts if patient is going to be readmitted within 30 days post-discharge from that incurred admission. So just for a second. Okay, there we go. So I'm going to start with the reflection. If any given moment, we have two options: to step forward into growth or to step back into safety, by Abraham Maslow. So I feel that our team did exactly that. We, prior to discovering this model, we used PRISM, which was a proactive patient risk prediction tool that allows us to predict if patient is going to be readmitted within 30 days post-discharge. And when we switched to Epic, that option was no longer available. So we decided that at that point, we needed a different tool that will help us risk stratify our patient population and know more about who to focus on in a acute care setting, as well in a post-acute care setting and ambulatory care setting. So we have a statewide team that is focusing on reducing unplanned readmissions and is using this tool. And this presentation today will be dedicated to the work that that committee and a work group has accomplished so far. So I mentioned PRISM as an option that was available to us in the past that we used to identify patients who are at high risk. At that time, we did not have, when we started using PRISM, we did not have a better tool to use. So we kind of decided to use whatever it was available to us at that time. And that tool actually, PRISM, has advantages and disadvantages. The disadvantage of the tool was it's driven by human input. So when we switched to Epic, the process became even more complicated. we moved the process from one step to two-step process where a physician had to put the order in and complete the survey in order to score to be generated. And once we officially transitioned to Epic, that was no longer an option. And as you can imagine, we had patients without the PRISM score, physicians forgetting about completing the survey. So we, like I said, had to find something else. And luckily, Epic, in addition to tool that I'm going to be, or a model that I'm going to be talking to you about today, has other tools that are more applicable for a ambulatory care setting. But we felt that from our standpoint, to close that loop from acute care setting to post-acute and ambulatory care setting, this is the best tool that we decided to focus on. So it is a tool that determines if patient is going to be readmitted as an unplanned readmission within 30 days of being discharged from that index admission. And this tool, in order for work, patient has to be fully admitted. So it doesn't apply to ED patients. What was great about this tool is there is no human input and less options for human error, because the variables that are taken into consideration, everything kind of happens behind the scene. And Epic takes a snapshot of the patient condition throughout the stay. So upon admission, throughout the stay, and one sample at the discharge. The only disadvantage with that was when we started designing our interventions, we had to pick if we're going to use the score that was calculated upon admission or when patient is discharged, because that score could slightly change depending on how patient is doing throughout the stay. So the model uses a scale, low, medium, or high. So low would be 0 to 11%, medium 12 to 22, and high equal or over 23%. So in order for us to pick the patient population to focus on, we said we're going to start with patients whose score for Epic or EROR score is at 23% or higher. So what goes into calculation of that score that I was referring to? So admission diagnosis, problem is generated in ED. And then following diagnosis, anemia, AMI, cancer, PVD, AIDS, COPD, liver disease, CHF, RD, dementia, drug abuse, diabetes, renal failure, some specific source of tumor, fluid, and electrolyte disorder. So in addition to diagnosis, it also looks at current age of the patient, specific labs. I listed them on this screen, looking back 72 hours, not just the number of medications, active medications that patient is on, but also specific medication categories, specific order types, and utilization, which was really important for us when we were selecting what to focus on from an ambulatory care standpoint. So under utilization, you can see current length of stay, if patient has a follow-up appointment schedule, number of past ED visits, past hospitalizations. So when it's all of that calculated, what happens is in Epic, there is a score that is generated that based on a percentage allow us to decide if we want to focus on low, medium, or high risk patients. And as I mentioned earlier, to start with, we are focusing on patients who are at high risk. So if you are currently using Epic, the basic version of Epic that you have will have ability to generate this score. Like I said, things are happening behind the scene. There is no human input or any calculation that has to be done manually. Everything is calculated behind the scene. You can access it if you add it to your list of your daily patients, or if you are in a patient chart, you can also access it. So what the physicians do, if you hover over the score, you can see the factors that are included in calculating that score. And then if there are more than what's listed on the screen, if you click on it, you can see the rest of it. So for this patient, what identifies patients or classifies patient as at high risk, if you look at the number of active RX orders, there is 52. Patients had 2 previous ED visits. Some labs are included. And I'm pretty sure there is information about length of stay and other things that we mentioned. Is just what I was able to show at this point is just these variables. So now we have a tool. We decided that this is the tool that we want to focus on. What are we going to do about the tool? like I said, the idea from the very beginning was to start in acute care setting and move to post-acute care setting and ambulatory care setting, making sure that everybody is using the same tool to identify patients who are at high risk. So this initiative now is a statewide initiative led by Chief Clinical Officer for Southeast Michigan. And I'm supporting it from a project management standpoint. There are actually 3 teams that are working on different things. Team A is working on making sure that patients have follow-up appointment scheduled. We have options for online scheduling that is now available, where the appointment can be scheduled while patient is in the house, or the ambulatory care manager can schedule it. Our team B is focusing, and we're going to spend majority of the time today talking about team B. That team B was charged with selecting first a diagnosis to focus on. We knew that we have a tool, but we wanted to make sure that we even stratified that patient population, risk stratified that patient population even more, and select specific diagnosis to start with. We wanted that team to be data driven, and I'll show you some data that we used to determine what diagnosis to focus on. And then we were charged with developing the best practice strategies that are applicable in acute care setting and that can be applicable in a post-acute care setting, so focusing on that transitions of care. And then we have a team C that is focusing on health disparities and social influence of health and impact of these on readmissions. So the team B that I was mentioned, Trinity Health has 7 hospitals in Michigan. So we really wanted to have representations from all 7 sites. So our team B includes 7 physicians. There are 5 directors of case management from each site that participate in this team B work group. And there is a MDA, which stands for Michigan Data Analytics. That is a department within Trinity that is responsible for our reporting, data analysis, and helping us with really looking from a data standpoint what the focus should be. So what was the purpose of our team? So there are few steps that we went through before we developed a standard set of interventions that I'm going to share with you in a minute. So first, as I mentioned, we wanted to use the data to see what that targeted diagnosis should be. We knew that COPD, AMI, CHF, pneumonia, all of these diagnoses are bringing our patients back, but we wanted to make sure what to focus on to start with, and if we pick one diagnosis, that we'll see the biggest impact on our readmissions. So our step 2 was really to do the inventory of what is currently in place in hospital-based setting. The step 3 was to really come up with the interventions that we can propose and say, moving forward, we want to focus on this because we think that if we do that, our patients, we're going to have less readmissions. And then step 4 was to rank these interventions in specific order so that we know what to start with, and what are the all interventions that we want to focus on, but what was the priority. So what's happening in the post-acute care setting? We have a very strong network of the post-acute care providers that includes home care and skilled nursing facilities that we work very collaboratively on, and actually provided a training sessions related to CHF, what to focus on when patient with the CHF goes to skilled nursing facility or goes home with the home care. So picking the CHF as a diagnosis made perfect sense because our post-acute care providers have been working on it already. So what we wanted to do is to make sure that if I have a patient in acute care setting that I'm transitioning over to post-acute care setting, either SNF or a home care, that I know that that patient is at high risk according to a tool that I was using. How am I making sure that our post-acute care providers are familiar with the same tool, can access the same tool, and can prioritize their work so that we can all work on eliminating the opportunity or minimizing the opportunity for that CHF patients to bounce back as a readmission. So for our post-acute care providers, they clearly don't have access to Epic because Epic is more like for Trinity Health employees and employed physicians. But there is an option in what is called Epic Care Link, which is a additional, it's an extension of Epic designated for post-acute care setting or ambulatory care setting. So the score, the same score that I showed you earlier that we are using in acute care setting, that shows the patient that is at high risk for readmission, is also available in a post-acute care setting. So that risk, we provided our post-acute care providers with a directions in terms of how to find the score, how to run a report on their patients to see which patients are at high risk. And then we didn't stop there. We spend a lot of time at our regional meetings educating our providers, post-acute care providers, on where to find the score, making sure that they, first of all, that they have access to Epic Care Link, and if they don't, to give them access, and second, that they know how to find the scores. So like I said, they can also risk prioritize their patients as well. And then we had multiple meetings with our, I'm going to go back to this slide. We had multiple meetings with our post-acute care providers in terms of, now you have a tool, now you know that a patient is at high risk. I, as a hospital, am sending you a patient that is at high risk. What are you going to do about that patient? We really wanted to develop a best practice model for skilled nursing facilities and home healthcare agencies to say, if you know that you have a patient that is coming to you that is at high risk, these are the things that we all agree to focus on when we're getting that patient. So we call it best practice model for skilled nursing facilities, and it is daily at-risk meeting, getting the patient to sign a consent for our remote patient monitoring. Upon admission, any potential rehospitalization risk patient might have are discussed with a physician or MP, and any changes in patient conditions are the notification is automatically sent to either MD or NP. High-risk patients are always reviewed in daily clinicals, so focus on the labs, vitals, weights, therapy levels, and like I said, any significant changes are communicated. And then for a high-risk patient, assessing nursing notes and order change daily, and really focus on these daily at-risk meetings where these things are discussed. If we know that patient is at high risk, these are the things that we, like I have a plan in place what to do for the patient that is at high risk. That was on a SNF side. And then we also had our team meetings or a work group dedicated to home care agencies to say, okay, if patient is going home with the home care, what the home care nurse or a home healthcare agency should be focusing on. So we agreed to that if patient is at high risk, according to that score or the model that I share with you, all new admissions are seen within 24 hours versus 48 hours. So we want to care to start within first 24 hours when patient goes home with the home care nurse. Front load visits in first 2 weeks of care when patient is at high risk. Offer and provide remote patient monitoring as long as patient qualifies. So every patient that is at high risk, if patient qualifies for it, remote patient monitoring is offered. Make sure that the follow-up appointment is scheduled either with a cardiologist or a primary care physician. Have a rehospitalization prevention plan. We do review our readmissions with home care agencies, so we want to make sure that these patients have a plan in place to prevent them from being rehospitalized. That there are case conferences that are happening 2 times a week versus once a week. There is involvement of a social work when there is a need to address social determinants of health, and then have a clinical conference with the clinical staff to kind of focus on these things, really focus on palliative care needs and hospice if they are applicable, and making sure that we are doing everything that we can to prevent that patient from coming back. In our ambulatory care setting, our ambulatory care managers were also introduced to SCORE that is available either in Epic or Epic Care Link, where they can prioritize their daily workload. to say, okay, I'm getting the patient, I'm following the patient with the CHF that is at high risk. I want to make sure that patient has medication, that follow-up appointment is scheduled, that education was provided, and if not, provide that education. And then also our pharmacy team, through their pharmacy outreach program, also utilizes a tool to identify patients to focus on with the CHF that are at high risk of being readmitted. And I believe that is my last slide that I have to share with all of you today. So what questions do you have for me?
Thanks so much for your presentation, Belinda.
Of course.
Does anyone have any questions for Belinda today?
I have a question, Belinda. I was just curious if you have any advice or recommendations to share about barriers that you maybe had during implementation, specifically around like this, getting staff to use the SMART phrase, or getting engagement from the SNF or home care agencies that you had to collaborate with to make this work. And I also want to say really great presentation that came in the comments too, but I second that.
Thank you. So from a post-acute care standpoint, as I mentioned, we have a very strong network of the post-acute care providers, and we've been working with them for years. So they did not see this as a one more thing to do, because it also helps them with prioritize their patients to focus on, because as you can imagine, they get bombarded with admissions, and it's really difficult for a nurse that works in a post-acute care setting to say, what if I know the patient is at high risk, what to focus on, right? There are so many things that I can focus on, but what are the most critical things I should be focusing on? So we did not really have a huge pushback. It was more about making sure that they all have access to Epic Care Link when the risk score is available, rather than actually implementing. And the other thing that we did that I think it helped is we really didn't design the best practice model. It is the work group with the representation from SNFs and home care, two separate work groups, where we met multiple times and say, this is your best practice model. This is what you can agree to. Because from a hospital standpoint, I can tell you what we think you should be agreeing to, but if it's not doable, then what's the point? So we really utilize and use their feedback when we're designing those models to say, you are saying that you're agreeing to this, so the expectation is that it's fully implemented because you kind of designed it. It wasn't designed by a hospital administration or anything like that. It was really the model that they thought that they can agree to. From a staff standpoint in an acute care setting, the SMART phrase is used as a reminder. So it's not, if things are already in place, it's not, the intention is not to replace what you're currently doing, but it's more like to standardize it. So we have, to be honest with you, we have different versions of the SMART phrase. One is embedded into first progress note. One is done when patient is started on admission and then added to discharge summary. But the intent was really to remind hospitalists and a staff to focus on these things. So it's not really how the SMART phrase looks like. It's just that making sure that all the components that we wanted our staff to focus on are included. So that when you, the idea was really to use it during the IDRs in the disciplinary rounds to go like a checklist. Okay, does patient have daily weights? Yes. If no, order daily weights. Does patient qualify for palliative care? Yes. If they're palliative care consult, no, order it. Did we do medication reconciliation? No. Who's gonna do it? So it was more like a team approach in terms of what needs to be done before that patient is discharged. So the difficult part is sharing it with that many hospitalists, right? Because we have many, but we kind of avoided that through, if we're doing it during the IDRs, then we have a resident that is responsible for initiating the phrase. And then as we continue to revisit the patient on a daily basis, things are added or other things are put in place, versus sharing the phrase with that many hospitalists, which is almost impossible.
That's very helpful. Thank you very much.
Thanks, Belinda. We do have two questions in the chat from Mary. The first is this tool only available via Epic? And the second question is, what results have you seen using this process?
So the tool is only available in Epic or Epic Care Link. If you are not an Epic user, then you will not be able to see the tool. Epic Care Link is, as I mentioned, as an extension of the Epic that is used by post-acute care providers. So, but the system has to have an Epic in order to get that Epic Care Link as well. So to answer that question, yes, if you're not using EMR, Epic as one of your EMRs, then you will not be able to see the tool. In terms of what are the benefits of it, we did see the increase in number of CHF readmissions. When we started, I think the statewide was 20.9%, something like that, and we are at 18.7, I would say, at this point. So we are seeing impact. And I think the reason why we're seeing it is because we kind of decided, like I said, to close the loop. We don't want to do ambulatory acute care setting. We want to educate the post-acute care providers and ambulatory care managers / pharmacy team on using the same tool. And I think that made a difference.
Wonderful, thank you. Does anyone have any other questions for Belinda today? I did have a question for you. So I did see on your slides and what you discussed is one of the teams is focused on health equity and social influences of health. I had a question. I was wondering if there had been any thought or any idea of incorporating the social influencers of health into that risk score, if that's been talked about or something that's kind of a future thought.
So the risk score, I think it's created by Epic, and I don't think that there are any ways that you can modify what goes into that score. However, Epic has a SIOH survey that can be completed. Depending on, some facilities have complete that survey when patient is admitted, others when patient is discharged. There's also availability to complete it in ambulatory care setting. And then based on the survey, there are action steps that need to be taken to address whatever the need is that survey showed. However, the connection between using that for the patients that are at high risk, we haven't made that connection yet. And the reason for it is because we are in acute care setting really struggling with utilizing the survey. We have a higher percentage of utilization in ambulatory care setting versus acute care setting because it's the focus of community health workers and social workers to focus on these things. But like I said, in acute care setting, it's not always priority to focus on SIOH because, patient is, has other problems that we are focusing on. So to get the staff to complete the survey is a little bit challenging versus in ambulatory care setting. But to answer your question, I'm not sure that we can add any component to what goes into calculation of the score. But like I said, we're really trying to make sure that our compliance rate in terms of completing the survey is a little bit higher before we make any changes. But definitely recommendation was to use the SIOH survey on patients that are at high risk for being readmitted.
Wonderful, thank you.
This is Mary. I have a question about how you implemented the actual tactics that you're using to decrease the readmissions. For example, what was the hardest piece to implement, and how do you monitor to make sure all the components are being accomplished?
So the hardest thing to implement was actually 7 sites agreeing that IDRs are best place to start. And the reason for it is because not everybody has residents participating in IDRs. So we had to come up with alternative ways of who's going to be initiating the phrase. The phrase that I'm referring to is that SMART phrase that I talk about it. And the reason why there was a challenge is because imagine 7 sites, how many hospitalists we would have to share the phrase with. So then we said, okay, we have to find point of contact or somebody that's going to be responsible for that phrase. And the IDRs made perfect sense because it's one resident that is responsible for initiating the phrase and then adding things or looking at it on a daily basis. The alternative was to have care managers initiate the phrase if there are no residents that are participating in IDRs. In terms of monitoring the process that we implemented, we are lucky to have a whole department dedicated to reporting called Michigan Data Analytics. They were able to come up with a report that based on the user will tell us, these are the component of the smart phrase, this is who initiated it, and this is, and when we run a report, these are the things that haven't been in place. The report is a weekly report that help us say, okay, that patient had, and it's not real time in terms of I get it tomorrow and then I see that palliative care consult hasn't been implemented yet. It's more to monitor if we are using the phrase and if we are using it accurately, and if we are not using it, which disciplines are not using it. So it's more from a monitoring standpoint rather than making changes in a real time at this point. Did that answer your question?
It did. Thank you very much.
Okay, you're welcome. Did you mention the impact Iris mentioned? Did the intervention work? Oh, there was a question. Did we mention the impact of identifying the high-risk readmissions to actual? Yes. So there was an impact. Our percentage statewide for CHF readmission decrease in terms of readmission rate for patients with the CHF. I cannot say 100% that it's only due to this because there are many other initiatives, as you know, that are put in place to reduce readmissions, but I think definitely help with reducing that overall readmission rate. Any other questions for me?
Linda, I'm not sure if Christy had already asked you this, but I'll just ask it since we're getting questions about sharing slides and stuff like that. Are you okay with us providing your email address?
Yes, absolutely.
Okay. Just wanted to confirm that. I thought Christy had mentioned that. But...
Yep.
So for those of you who are on, if you have questions that come up later, you'll get the slides from today. And then we can also connect you with Belinda.
Mm-hmm.
Wonderful. I will go ahead and bring up my screen to close out the work group if we don't have any other questions. Thank you so much, Belinda. So
you're welcome.
I'm going to share my screen. I just wanted to review some upcoming work groups that we have. So at the end of January, on January 25th, we have a sepsis work group that is going to highlight an update on HMS's work and the new sepsis toolkit. And then moving into February, we have a preoperative testing work group on February 6th and a cardiac rehab work group on February 22nd. The topics and presenters of these work groups will be announced shortly. So stay tuned for our blog post and MailChimp announcement on our February work groups. As a reminder, all work groups are scheduled via Zoom, and all work groups for 2024 will be occurring from 12 to 1 p.m. You can register via these slides, and you can also register via the MVC events calendar that's located on our website. So thank you again for being here and participating in today's work group. As a reminder, the work group survey has been posted in the chat, so you can follow that link and complete it. I also will be including the link in the follow-up email. For hospitals that are hoping to get engagement points for this work group as part of MVC's component of the P4P program, this survey is required. For all others, the survey is optional, but highly encouraged. We always appreciate your feedback. If you have any questions, please reach out to us. If you have any questions for Belinda, we'll include her email in the follow-up email as well. And have a great rest of your day. Thank you so much for joining us today.
Bye, everyone.